risks of LV unloading while on VA ECMO support. And so in my mind, the goals here are to understand the what's in the peer-reviewed literature, focusing in on those prior publications, and importantly, doing a deeper dive into the more recent manuscript that it contributes to this body of work, and then having some take-home messages that positions us, which is always most important, how to care for patients supported by VA ECMO. And so appreciate the opportunity to help, moderate and carry this along. And Zach Il'Giovine will take it from here. Zach?
Well, great. Thank you, everyone, for having me. As Dr. Estep said, I'm Zach Il'Giovine. I'm one of the third-year general cardiology fellows, and we'll be talking about this article on LV unloading. Let me just take control here and bring my slides up. All right, can you see my slides?
Yep, yes. Looks good.
Perfect. So the article that we'll be discussing today is this article that was recently published in Circulation last month. Left ventricular unloading is associated with lower mortality in cardiogenic shock patients treated with VA ECMO, and this was an international multicenter study cohort. Before we jump into the article, as Dr. Estep mentioned, I do want to frame it. So for the first 10 or 15 minutes, I do want to just go over where we've been, what the work that led up to this current paper was, and just a general rationale of why we're even discussing this. And so why unload? I know I am preaching to the choir a little bit here, but we want to cardiac unload because it reduces mechanical power expenditure to the ventricle. This minimizes myocardial oxygen consumption. It can help deter some of the forces that lead to adverse ventricular remodeling. And in acute MI, it can reduce infarct size. I do want to spend just a second on this. I won't dwell on it too long. We'll focus on the first 4 panels, panels A through D. And so this is a pressure volume loop, and you can see the end diastolic pressure volume relationship here. A represents mitral valve closure, and then the onset of isovolumic contraction through B. This is aortic valve opening, blood ejection. C is aortic valve closure, the onset of isovolumic relaxation, and then diastolic filling. And this end diastolic pressure volume relationship here is characterized by passive ventricular properties. So ventricular compliance is what drives the slope. And you can see as volume, left ventricular volume increases or left ventricular pressure increases, that slope changes. Panel C is an example of pressure volume loop in an acute myocardial infarction. So you get a shift to the right, you get a decrease in the end systolic pressure volume relationship. And as you can see, you get a decrease in stroke volume. In panel D, if that persists, you get adverse ventricular remodeling. You shift, and you can shift further to the right here. So why unload? If you look at this black line right here, this is a good representation of what a pressure volume loop in an acute myocardial infarction or chronic heart failure might look like. And as you look at the different colors, this is what happens if you place a continuous left ventricular flow device. And what you'll see is as you start to unload the ventricle, you get this more triangular shape because you lose isovolumic contraction and relaxation because it's continuous flow. And you also start to shift more favorably to the left here with decreased pressure and decreased volume. And then the other thing to point out is if you look in panels B, C, D, and E, what that's showing is aortic pressure on the top here and left ventricular pressure. And as you increase support, A through D through E, you'll see there is uncoupling of what the left ventricular pressure and what the aortic pressure is. And so as you have a device with more support, what your systemic or aortic pressure is less related to what your ventricular pressure is. So patients on VA ECMO, so who cares about what is happening to the ventricle? And I think this is a nice kind of summary figure. In shock, your pulmonary capillary wedge pressure is elevated, and when you place a patient on VA ECMO, that actually increases their left end ventricular end diastolic pressure or their wedge pressure even further. If you add a device like an Impella, you can decrease your end diastolic pressure and your pulmonary capillary wedge pressure. And so although ECMO can reduce central pressure and improve end organ perfusion, it causes this marked increase in left ventricular afterload. And so you can have, as I said, left ventricular end diastolic pressures and pulmonary pressures that increase, and an already failing myocardium is further injured. And so the early signs of significant LV impairment function can be a loss of pulsatility against the ECMO flow. And in clinical practice, this looks like pulmonary edema, LV dilation, LV stasis, or LV thrombus formation. And so one of the papers that I wanted to talk to that kind of led to the paper that we're going to discuss was by the same group, actually. And this is a paper looking at LV unloading during VA ECMO, and this is just this was published in JACC in 2018, and has a nice summary here. What this shows is what a typical pressure volume loop in cardiogenic shock looks like, and when you add ECMO, you see it shifts to the right because of that increase in afterload. And so in this panel, you see you get this favorable increase in aortic pressure, systemic perfusing pressure, but you get a concurrent increase in wedge pressure, which can be unfavorable. If you add an Impella, you'll see this becomes triangular shaped because you lose isovolumic contraction and relaxation because it's a continuous flow, but you shift more to the left, and you then uncouple these two pressures, and so you get favorable increased systemic pressure, which is good for organ perfusion, but you also can decrease your wedge pressure, which favors myocardial recovery. And so this was a systematic review that included just about 4,000 patients with cardiogenic shock who were placed on VA ECMO. 58% of them without LV unloading, 42% are just under 1,700 with LV unloading. And you can see the breakdown there. The vast majority of patients, over 90%, were with an intra-aortic balloon pump. A smaller proportion was with a percutaneous LVAD, like an Impella, or another small percent with surgical unloading. And this showed that in general, unloading was favored, but you'll see Impella was a very small proportion of this study, and the results were not quite convincing one way or the other. There were only 49 total events with LV unloading with Impella in this study. And so then another study came out. This was in circ heart failure at the just about a year ago, and you'll notice some familiar names in the author list here. And so I'll have Dr. Estep and Dr. Soltesz. I think I saw Verinder on the call as well if they want to comment. This was a larger study, almost 8,000 patients from 62 observational studies, almost 3,500 of whom had an LV vent strategy. And this was looking at not just the consequences of unloading the ventricle, but also timing to the vent strategy. And you can see that because this was a retrospective review looking at what was already out there, this was also very heavily balloon pump favored. with a slightly higher proportion of peripheral VAD, and they did actually break down what it was with. So Impella 2.5, Impella CP, and then a smaller proportion of Impella 5.0. And then 6% were things like atrial septostomy, direct LV apex cannulation, or pulmonary vein cannulation. And this show, I think importantly, this showed that LV unloading was associated with significant reduction in short-term mortality. And the definition for short-term was 30 days. So it decreased 30-day mortality. However, this was driven by balloon pump, and no differences in short-term mortality were noted in any of the other modalities. And so you can see here again, overall it's favored, but the vast majority were driven by balloon pumps. Impella was a smaller proportion, surgical vent mixed strategies as well. And some secondary outcomes that they looked at were in hospital or long-term all-cause mortality, and you can see that there was a reduction. It was a non-significant reduction in both of those. And those findings were the same whether a patient was centrally cannulated with VA ECMO or not. The other interesting portion, and this is going to be important again for this study we're going to talk about tonight, is that the time to vent to the vent was important. So mortality was decreased by early but not late LV venting strategies. Early here was within 12 hours. There was still no statistically significant change in hospital long-term mortality, regardless of timing. And then there was one study that showed it didn't matter the timing, but that was kind of an isolated type thing. Another thing that's going to be important, again, for what we talk about here in a bit, is that the use of the vent was associated with a significant improvement from weaning from VA ECMO. You see the odds ratio there is 0.62, and was particularly for early strategies. It was not seen with the late strategy, and so there was no difference if the vent was added past 12 hours.
So, Zach,
yes.
Thank you for that. You know, you're setting the stage for the article to be discussed in more detail, and I think that's always very nice to do up front, and starting to get this signal, right, of maybe mortality benefit, and timing's important. And, you know, we have Verinder on the line, who was, you know, primary author, first author, working with our colleagues from Canada. And I don't know if Verinder can speak to the challenges when working with such a data set to try to tease out time, right, in terms of 12 hours or less. And so, Verinder, if you could just comment for the group.
Yep.
The observation related to time and challenges we had.
Correct. And I think that's where today's study might position things a little bit with a little bit more granularity. So when you look at all of the retrospective data that are published, it's very hard to tease out protocols that are clearly defined in the methodology. Many of the studies would have said concomitant VA ECMO with LV venting, or sort of shortly thereafter. You'll notice in a lot of these studies, there was an escalation of therapy. So oftentimes patients were on an intra-aortic balloon pump or Impella device, and then had subsequent VA ECMO added to, so may not have been driven by an LV venting strategy from the get-go. And then we sort of were very comprehensive in looking at the definitions of presentation through the methodology, as well as contacting the authors who wrote each of the retrospective studies for clarity in order to do this meta-analysis with the group. So it was not easy. It took us a long time to get that level of granularity, and we are thankful for the authors who provided additional input to help with this analysis.
Great, thank you, Verinder. That's awesome perspective. The other thing that I wanted to point out from this study is that, again, this will be kind of a theme, is that a higher proportion of patients were weaned from ECMO with the venting strategy, but they had more days on VA ECMO. They had more mechanical ventilation, but there was no difference in ICU length of stay. And so the conclusion really was that that LV venting was significantly associated with improved weaning and reduced short-term mortality, especially if implemented early, and that patients might have associated longer duration of mechanical ventilation without impacting overall ICU length of stay.
So Zach, real quick, if I may, just because I think as we get questions that come up relative to what's been published, and we're certainly going to look forward to tackling questions after we review the manuscript. One of the ones highlighted thus far in terms of questions is how important is LV size versus time in terms of the benefits risks of LV venting. And when you start to quantitate LV size, you certainly need some surrogate of size above and beyond X-ray like echocardiography. And so, looking at these retrospective studies in terms of LV size and its importance, certainly there's some challenges to do so. But I don't know if you have any comments on what you may have seen or not related to the importance of LV size in the manuscripts you've already reviewed. Again, setting the stage.
Sure. So I think, as Verinder said, with these retrospective studies, especially when you're enrolling thousands of patients, and there were from different centers, from different countries, and there was no set protocol, not all of that information is uniformly collected. And so I did not come across any clear data, retrospective observational data that supported looking at LV size, but certainly I'm not sure if you or if anyone else is aware of anything that might exist in the literature.
I think we're limited to case reports, Zach. That may comment specifically on LV size, but when you're looking at big retrospective studies that are published, they do not often provide that granularity.
Yeah.
And then, so this is Venu. So at least, we did perform echoes on everybody in the shock trial and acute myocardial infarction setting. And clearly the biggest predictor of death there was a small ventricle. And that was especially thought to be because you can't produce stroke volume with a small ventricle. And so a small ventricle in the setting of an acute myocardial injury is certainly bad compared to having a dilated ventricle.
Venu, thanks for that highlight. And then I think what we can address towards the end of the talk is LV size considerations in terms of venting strategy, if you believe in, early venting or not. And so we'll certainly come back to that concept of LV size and guiding decision making.
Great, thank you, everyone. And so the last thing to say about this study is this very nice, I think, portion that really encapsulated in the manuscript, and it said that although we attempted a comprehensive analysis of LV venting mechanisms, there's a lack of randomized data and fewer studies reporting use of LV venting mechanisms by things other than intra-aortic balloon pump. And so if you look at Impella specific things, this was the first description of a large series of patients who were treated with a combination of ECMO and Impella. This was published in 2016. And I'm going to put large in quotes because it was 157 patients and 34 of them had Impella. And so this study did a propensity matching analysis in a 2-to-1 ratio. And so they had a study group of 21 patients with VA ECMO and Impella that they compared to 42 patients with VA ECMO alone. All the Impellas in this study were an Impella 2.5 or an Impella CP. There was no Impella 5.0 or 5.5 at the time. Overall hospital mortality in this study was 73%. And patients in the VA ECMO plus Impella group had lower hospital mortality and a higher rate of bridging to recovery or the next therapy. Bleeding was not different, but hemolysis was more frequent. Renal replacement therapy was higher in the Impella group. And as we saw before, mechanical ventilation was longer in patients when the vent strategy was employed.
But just to be a damn squib on this, when you take a look at the mortality difference, 47 versus 82% in this kind of an observation with this kind of a substrate, you know how little reliability you have in that kind of data. This, if you get that kind of a treatment effect, we would be talking about doing a randomized clinical trial of 30 patients and proving it to be positive. So
sure.
I would hope that there is a significant amount of skepticism in all of this data that's produced.
Absolutely, and that's what I wanted to really highlight here is that there are these studies that maybe looked at signals, but the populations were so small that it's really hard to make a significant conclusion from it. This was their propensity matched analysis. We're going to see the propensity matching in our study that we're going to talk about today. But what they showed in the matched cohort was that hospital mortality was lower, as Dr. Menon pointed out. Bridge to next therapy or recovery was lower, or was higher rather. Weaning from MCS was higher, but the duration of mechanical ventilation, renal replacement therapy, or hemolysis, as expected, were all also higher in the Impella group. There was no difference in this study between major and minor bleeding, and that's something I do want to come back to, as Dr. Menon pointed out. You have to really take what you're finding with a grain of salt when the study is this size. So here's a much larger study that was published in 2018. This was 106 patients with VA ECMO and Impella combination. There was more successful weaning in patients who had Impella in this study. 12 of them, as Virender's saying, there's sometimes being upgraded, having support upgraded, that's not quite captured. They were actually able to capture that 22% of their study population had to be upgraded from an Impella CP to an Impella 5.0 to wean. And then of those 12 patients, 5 went on to receive a durable VAD. 7 could be weaned from that 5.0. And then there were no heart transplants in that study. And so now we're going to move on to talk about our study tonight that we want to present. But as a quick reminder to everybody, these are the different types of Impellas now on the market. You can see the differences in cardiac output that each can provide, and then the 5.5, which is not actually represented in our study or that we're going to talk about, or any of the studies, because it's a little bit newer. It is here as well, and it does have this Smart Assist advanced metrics that I won't talk too much about. I'm not sure if Dr. Estep, you wanted to make a quick comment before we move on.
Well, yeah, I think with the 5.5, those advanced metrics are derived by an algorithm and calculations. There's some assumptions, and you really shouldn't use the degree of you shouldn't adjudicate adequate LV unloading, in my mind, by the advanced metric surrogates alone. And we're going to talk about what is LV unloading and how do you measure success or failure. And so it's improved technology, but it's not replacement technology in terms of looking at hemodynamics with a SWAN and bedside exam, in terms of understanding appropriate degree of LV unloading or not. But it's a step in the right direction. I don't think we need to spend too much time, other than highlighting, certainly not included offers robust support.
Right.
So let's walk through the manuscript at hand.
Perfect. As we just kind of set up, the primary aim was to evaluate outcomes in patients with cardiogenic shock treated with VA ECMO with LV unloading, specifically with an Impella, and without LV unloading. You're going to see this term now called ECMella, or here we call it ECPella quite often. But they wanted to, there was this suggestion that it could be used to treat patients and may improve outcomes. The published evidence comparing VA ECMO alone to an ECMella strategy is limited, to say the least. And so they were able to generate a much larger in comparison study to what had previously been seen. So this was 686 consecutive patients with cardiogenic shock who were retrospectively enrolled in this registry. And I'll point out the timelines. VA ECMO alone drew from the years 2005 to 2019. The ECMella strategy, because it is newer, sampled patients starting in 2013. So that was 2013 to 2019. So take that in the context of any other developments or changes in treatment or care that could come up in that period of time. And then this was 16 centers from 4 countries. All of them were large centers experienced in treating cardiogenic shock and were comfortable using mechanical circulatory support. The only exclusion criteria was post cardiotomy cardiogenic shock or age below 18. And so their primary outcome was a 30-day all-cause mortality, similar to the short-term mortality that we discussed prior. And the specific safety endpoints that they wanted to adjudicate here were bleeding complications, which were defined by the Gusto criteria. So intracerebral bleeding, hemorrhagic stroke, intervention due to bleeding or hemolysis, ischemic stroke, intervention because of access site related ischemia or laparotomy due to abdominal compartment syndrome or bowel ischemia. And then other safety endpoints were things like hypoxic brain injury or renal replacement therapy or sepsis. And sepsis in this study was defined as SIRS criteria syndrome with at least two positive blood cultures. And so for this analysis, missing data was handled by multiple imputations with chained equations, and they also, as we saw in that other study that I mentioned, used a propensity score by a logistic regression model, and then averaged in the imputed data sets. And so these were the propensity score variables that they used: age, sex, cause of shock, whether or not a patient had prior arrest, whether or not ECPR was present, mean blood pressure, heart rate, lactate, and pH. And they were matched 1-to-1 with patients treated with VA ECMO only. And in their analysis, they wanted to look at pre-specified subgroup mortality, which I'll talk more about, specific safety endpoints, and then, as with our group's study, timing of LV unloading and how it related to outcomes. And this looked specifically at Impella implanted before VA ECMO or within 2 hours versus after 2 hours. And so this was a much more tight window of what they called early versus late. So there were this was a well balanced between patients with VA ECMO and those treated with the ECMella strategy. This was predominantly femoral percutaneous access for ECMO in both groups. And you can see 337 patients with an ECMO Impella combination strategy is well more than any of the other studies that I presented. With propensity matching, that became 510 total patients, balanced with 225 in each group. And 225 is still, again, I think, a quite significant number of patients compared to what had been available previously. And so you can see the unmatched cohort is on the left, the matched cohort is on the right. The majority of patients with shock the cause of shock was an acute myocardial infarction. The vast majority of those were revascularized. you can see there was actually a difference in non-ischemic cardiomyopathy that was higher in the Impella group, as was eCPR use. And the types of Impellas that they, or what they showed was that Impella was planted first in about 56% or 188 patients, and the types of Impellas, the majority were Impella CP. There were some Impella 2.5s, a small proportion of Impella 5.0, and then a small proportion who were missing the Impella type. The medium duration for VA ECMO use in the Impella group was a day difference. So it was a day longer with Impella, 5 days versus 4 days. You can see the interquartile ranges there. The median duration of LV unloading within the Impella group was 6 days. And then of those patients, those who would go on to receive a durable VAD it was higher in the Impella group, though we'll come back to that with the matched cohort that did not sustain in the matched cohort. And so with the matched cohort, again, it was nicely balanced with a majority of patients having Impella implanted first, with 56%. The types of Impellas used were a similar proportion between the 2.5, the CP, the 5, or missing. As I pointed out before, there were no Impella 5.5s enrolled in this study. And the median duration of VA ECMO use was the same. It was a day different with 1 day longer in the ECMella group. The median duration of LV unloading in the ECMella group was 6 days. But those to go on to receive a durable LVAD were not different. Were not statistically significantly different, though you can see there is maybe some non-significant trend there. And then this is the big thing. So in both the unmatched and the matched cohort, there was a statistically significant survival advantage in patients who underwent VA ECMO with an LV venting strategy with an Impella. You can see the hazard ratio there is right around 0.8 for both. The confidence interval does not cross 1 in the matched cohort. And so I think this is maybe the most compelling data that had been demonstrated thus far about the mortality benefit. And amongst subgroups, you can see these were all pre-specified subgroups. The 30-day mortality was not different, but favored the ECMella strategy regardless of the age, regardless of the patient's sex, regardless of the cause of cardiogenic shock. Cardiac arrest was more heavily favored in the ECMella group. eCPR was not different. Patients who had a higher lactate, 5 to 10, under 5, it was a little more balanced, but higher lactates also favored the ECMella strategy. SAVE score, SAP score, and then you can see at the very bottom, overall, the ECMella strategy is favored.
And Zach, and with looking at that, forest plot in the context of the confidence intervals spanning over the line of unity and not significant in some, I think you can say pre-specified groups were defined. There's a suggestion of some efficacy, right, in one group compared to the other, but one could, and I'm sure we'll discuss, could put some criticism, right, related to the two groups being compared.
Yeah.
Zach, did you do a subset analysis or show the subset analysis of the patients in whom the Impella ECMO strategy was done simultaneously, or the Impella followed the ECMO? Because otherwise, the substrate changes dramatically.
Sure. We'll talk a little bit in just a second about timing, Dr. Menon. But in this forest plot, at least, they did not have it specified as one of the subgroups. But that is a separate secondary endpoint that they did try and look at as far as timing. Now, the other thing that I think is very important to bring up is safety. And you can see that in the ECMella group, there was more bleeding, both severe and moderate bleeding. There was more hemolysis, which I think was to be expected. There was more intervention needed due to access site-related ischemia, and there was more renal replacement therapy. And so while we saw we kind of expected the hemolysis, the renal replacement therapy, based on some of those prior studies, this is the first time we're seeing this signal that I think makes sense in a lot of our minds, that the bleeding might be higher, and the intervention related to access site related ischemia might be higher. And I do want to open this up to the group, but before I do that, I just want to, the authors kind of systematically address these points, and so I'll tell you what they said. They said regarding some of the bleeding, the addition of a second device, including the need for a second arterial access, increases the likelihood of bleeding and ischemic complications, especially as ultrasound-guided vascular access, which could reduce such complications, is not always feasible in cardiogenic shock. The underlying mechanism of the Impella, which is forcing blood through a small inlet and outlet, causes a high shear stress on blood elements and is associated with increased hemolysis. And then finally, higher complication rates, especially higher need for renal replacement therapy, bleeding, and access site-related ischemia might to a certain degree be explained by a survivorship bias, meaning that as ECMELLA patients had better survival and therefore longer follow-up, they were also exposed to more risk of complications. And so I do want to kind of open it up here to discussion, if anybody has any thoughts on the safety and the complications.
So I think the critical component of the manuscript, and hemolysis, certainly some may take the position that it's influenced by position of the pump, and certainly malposition may create more hemolysis, but I think we've all seen hemolysis with these devices. And so I think, what can be done to help mitigate, to create that potential advantage versus side effect profile. But when we look at extended support with the Impella in the acute on chronic heart failure world, one of the complications that I don't see here that we are seeing is infection. And I think it was perhaps the shorter duration in this particular cohort. And then bleeding, one always wants to put in the context of access and severity of illness. And I think renal failure is in the company of bleeding and challenges with hemolysis. And so I think one needs to be very cognizant of this adverse event profile in these patients with AV ECMO. And if you expand that out to a larger patient population, would that risk-benefit trade-off change? So interested in comments from others related to observations from the bedside, or how one puts this into perspective as we move forward.
Hey, Zach, I see Paul Kremer on. I don't know if Paul's on, but if he is, Paul's really an expert on propensity analysis. And I was just wondering, Paul, when you look at this data set from a methodological standpoint, from a propensity analysis standpoint, how does it look to you?
Yeah, thanks, Veno. I think the strength of this study from a methodological standpoint is the size of the cohort. What I would say from the propensity matching, like Zach, which you highlighted in that baseline table, I think that SD column is probably the absolute standardized difference of the mean. So those are not p-values, right? So, but what I would say in general in propensity matching, we don't want a parsimonious approach, how you might usually want when you're doing a multivariable model for an outcome. So I would say this is a pretty bare bones propensity model. So maybe they didn't have a lot of data points, but the more standard approach in propensity matching would basically to throw in the kitchen sink. That would be a typical way to go about it. Because you're really basic. So what are you doing here? You're basically building a logistic regression model saying, what is the likelihood that this patient would get an Impella, right? So you're basically identifying the patients who didn't get an Impella, who were most likely to get an Impella, or most similar to the patients who get an Impella. So that's all the propensity score is just a big logistic regression for likelihood of receiving the device. So here, I don't think that there's, they certainly could have had a more robust propensity model. The other thing which you highlighted, Zach, which would strike me methodologically as a concern, is the time difference, right? So their cohort spans a long period of time, but the ECMO, the Impella was only in the more recent years, of course. So to me, if I were reviewing this, I would ask to see a sensitivity analysis restricting patients just to that time frame of years. So I don't know if they did that or not. Right, the numbers would be smaller, but the practice of advanced circulatory support in 2009 versus 2019 could be very different, regardless of the Impella. So to me, just at first glance, that would be a weakness. And I would just say, I mean, this is, again, I think this is it's a very, it's a large cohort, it's multi-center, it's well done, but it's the kind of thing that it's hard to do propensity scores around these kinds of things, right? Because there's probably institutional variables and hospital variations and in terms of outcomes related to that are hard to capture in a propensity score.
Paul, thank you for the excellent comments, and certainly we'll want to highlight the limitations, which you've done so, in the context of take-home messages. Zach, let's move on.
Sure. So, and then this is just looking at subgroups for these severe complications. And I did want to point out that there were no differences between any subgroups except for there was a higher signal for bleeding in female sex for severe bleeding, which is highlighted here. And then Dr. Menon, this kind of gets into your question is, did they stratify anything by early versus late unloading? And their definition of early versus late was before ECMO was implanted or within 2 hours of its implantation, kind of simultaneously, or after 2 hours. And what this showed was that the early strategy, an Impella before ECMO being placed or essentially concurrently with it, there was a similar survival benefit here, a hazard ratio of 0.76. After 2 hours, there was not a statistical difference. So you can see there that the confidence interval of that hazard ratio is in the late group is 0.51 to 1.16. So I think that highlights again the importance of an early unloading strategy.
But Zach, those are just smaller numbers, right? Like
yeah,
that's just a type 2 error. And potentially the hazard ratio is the same in both.
So that's exactly right. If you look at the numbers at the bottom, it's exactly what Dr. Kremer just said.
And Zach, just to from Paul's standpoint, I mean, don't think about this like a researcher or like a statistician. If you think of it like a clinician, right? These guys are presenting to the same institution. And why the hell does that same institution treat one patient differently on day 1 and one patient differently on day 2 if they have the same surgeons and the same things available? So you would predict, it could be one of two things, right? One is when a person has a cardiac arrest and they have complete cardiovascular collapse, you have no time, you put the ECMO in first, then you think about the Impella. On the other hand, a guy comes in with an LAD infarction, you open up the artery, the guy's LV is down, you put an Impella in, he then goes into VFib arrest, and you put him on ECMO. So those same things are keeping on happening, which is why I think when you're trying, although these are signals, when you're trying to derive mechanistic reasons to validate a bias or even they have to be only hypothesis generating, because there is no reason why a patient should be treated in this institution differently on Monday versus Tuesday. And so there is, despite having that propensity analysis, Paul's point of this being a very limited thing sets you to say, are these truly still similar patients? Or are we seeing a divergence of curves here because of the support? Or are we seeing a divergence of the curves here because of the substrate? And that's something which is obviously impossible to figure out in a data set like this.
And Zach, and so that, when you look at the breadth of data you reviewed, very similar limitations, right? In these observational studies, we have unconfounding factors. We don't know how these patients were managed. You have two different time spans, right? More contemporary versus not. And so it becomes very challenging. But having said that, and we're not uncommonly in this position where we're managing these patients and we're trying to look at the signals and then maybe it doesn't change your clinical practice, but it positions us to say, well, what is the best next step to answer the question? And so I think the limitations are there, and please highlight them, because what I do want to get a discussion on is LV unloading and strategies that are taken, and we have critical care specialists, surgeons, really the full spectrum of expertise to talk about this concept and real practical take-home messages in terms of how we manage patients.
Yep. So then just I think that was a perfect highlight and segue into the limitations. So the big ones here that I think actually all of them were mentioned at some point. This was an observational study, and then even after matching, residual and unmeasured confounding cannot be totally accounted for. Other relevant data like cannulation size, anticoagulation strategy, other, I think, very clinically relevant, clinically useful things beyond the characteristics that were reported or missing. Hemodynamic data, both either invasive or echocardiographic, as Dr. Estep mentioned a little bit much earlier, it was also not captured in this registry. Some outcomes of interest like north-south syndrome, aortic root thrombosis were also not available. The generalizability based on experience using these devices, and then I think the one that we just kind of hammered home at the end there, which is that this was still the relatively small sample size of the matched cohort. And so I think that the takeaways were that LV unloading in select patients can be beneficial. Timing is important, and in general, earlier seems better. And the optimal strategy is unclear and likely patient-specific, but reasonable. Now I think reasonable retrospective observational data exists for balloon pump and now Impella. So thank you, everyone, and hopefully we can spend the last little bit here with more discussion.
Zach, so excellent presentation, review of the topic. Let's jump right into discussion, and I'll start off by asking a question. Does every patient that receives a VA ECMO, independent of underlying etiology, need device-mediated LV unloading? And so, Venu, you certainly see no shortage of patients coming into J31. You have to put them on a VA ECMO. What do you think about in terms of whether you need to escalate to a device, and can you achieve it just with pharmacologic and/or ECMO management considerations?
So I think, obviously the physiology that Zach so elegantly shown and would suggest that everybody needs it, and it makes perfect sense. I think we have a lot of surgeons and other folks in here. What I've been surprised by with this is there are some people who have lousy ventricles. You put them on ECMO and you get away with it without any pulmonary edema or anything else, whereas other people, right off the bat, you can see significant lung congestion. And it's been extremely hard for me to predict which one is which. I think it makes perfect sense to say I want to decongest the lungs and I'm going to provide support. But it's still, after all these years, it's challenging to me how some people just get away with it without getting that support, and I haven't been able to understand why they do.
Yeah, no, I agree. It really merits discussion about, well, what are we looking for to merit LV unloading if some patients get away with it just fine, whether it's lower ECMO support and maybe using some monotrope, and they're not having this adverse sequelae. So So, the use of SWAN to define LV unloading on concomitant ECMO, in my mind, that's a standard. I say that, and I know it's a strong statement. I think waiting for pulmonary edema by plain film or frothy sputum by physical exam or hypoxia, I think that's way too late. So I'd like to hear from some of our surgical colleagues that when someone's crashed on an AV ECMO, considerations related to LV unloading. Does everybody need a device? Can you get away with lower pump speed setting if you're so fortunate to have reasonable blood pressure and maintain some ejection with concomitant medical therapy? So Nico, I appreciate you're on the line. What's your approach?
Yeah. Hey, Jerry, this is Randy. Can I make a quick comment, please?
Of course.
So, I've been watching ECMO for 25 years at the Cleveland Clinic and long before we had Impella. And, we kind of stumbled on the fact that I think the common denominator is how much ejection does the native left ventricle have and how much of a problem is refractory ventricular arrhythmias, just as kind of a baseline. So early on, we saw these people going into pulmonary edema, and all we could do was a transeptal and put in something like a tandem heart or a balloon pump to try to temporize them. And I think if you were doing a clinical trial, you would take patients that need VA ECMO and just randomize them to right out of the blocks, putting an Impella in to try to answer the question. But the bottom line is, I think it does relate to some degree to how much ejection the native ventricle has. And as you pointed out, monitoring the LA pressure or the wedge pressure. So those are my perspectives.
Randy, appreciate your insight, and I am going to get back to you as I'm interested in next steps to maybe answer some of these fundamental questions with all the limitations in studying this patient population. So, Nico or any of the surgeons, if you guys just can comment on this topic related.
Yeah, definitely. I think there is an important value to the hemodynamic monitoring and the echocardiogram. Indeed, at the beginning you were talking about the size of the left ventricle, and so I think it's more important the pressure inside the left ventricle, right? Whether with a wedge or not. I think, as you very well described, when we look at this study, even with a large population of patients, you have a mixed group, different etiologies, so it's difficult to generalize. Definitely, we've adopting more recently the more aggressive strategy of unloading the patients, but definitely with an Impella 5.5 most recently, which I think is a more robust pump, gives you the opportunity to work over a wide range of drainage and eventually use it as a more robust pump to wean the patients of the VAS. You have decongested those lungs and improve the general volume status of the patient. I think the question regarding when to activate remains open. There is patients that is very obvious, and you will go and unload them from the get-go. But I think there is still certainly value to give a few hours and consider low inotropic support or so to decompress and do away without the device. Now, if we are going to unload, the concept that we've embraced in our group is to be aggressive and go with the Impella 5 or more recently 5.5.
So Nico, I appreciate that. One of the observations related to the device that's been used the most to help unload with these, I'll say, soft signals of maybe mortality benefit is balloon pump, right? Not Impella. And certainly some patients, balloon may provide enough support, not comparing balloon to Impella in terms of the degree of support you may need and the ability to help wean someone, right, on the back end to remove the ECMO. But I've seen some patients that are beautifully unloaded just with a simple balloon and concomitant, and you got to keep taking into consideration the bleeding, the hemolysis, taking someone for the Impella 5.5 surgically in the context of additional, or one can argue, risks. And so my bias is right now we don't know. There's obviously no, let alone the challenges with the data we have, data comparing one device to another. And I don't think you can say one device meets the needs of all patients. I think certainly you try to tailor it and weigh carefully that benefit risk assessment for that individual patient. But certainly open for investigation. So it's 6:58. I'd love to hear questions from those on or comments from anybody else on.
Jerry, it's Penny. I think I would just echo that as well in terms of thinking about true hemodynamic tailoring, because the question is how much unloading is sufficient. And that really depends on what the physiology of what's going on is. Obviously, if you're putting someone on initial support with VA ECMO with full support, they might not need much in terms of decompression, and maybe your balloon or maybe a little bit of inotrope or maybe a little bit of afterload is going to help that. And, am I able to wean my flows and able to support the patient sufficiently? I think kind of for me in a broader context, thinking about other healthcare systems too, is being judicious with the resource. And so thinking about what do I give to what patient, and how am I actually not overloading the medical system in terms of thinking about costs too. So I think there's lots of opportunity about thinking about what's the right device for the right patient, and also being responsible in terms of thinking about what's the cost associated with a 5.5. Am I able to unload sufficiently with a balloon for $800 versus a $35,000 device? And what's the underlying pathophysiology? So is that going to be enough? Once I start weaning my flow, do I need a 5.5 to achieve, my endpoint and my goal? So I think it's difficult because the population is so heterogeneous in terms of thinking about off the hop, where does my patient need to go? But maybe thinking about an initial strategy, providing full support up front, and then thinking about how do I unload sufficiently for at least the first 24, 48 hours till I make a next decision.
Excellent. Appreciate those comments. Questions from anyone else?
I think, Dr. Estep, the other thing that's pretty important, and I think just an extension of what Dr. Rampersad had alluded to, is perhaps the etiology defines the physiological presentation of the patient coming in. So somebody who comes in requiring ECMO in the setting of acute myocardial infarction, where there's an opportunity at recovery with revascularization, one might be able to wean off the device support, short-term support, perhaps quite a bit faster than somebody who comes in, for instance, with chronic heart failure from non-ischemic etiology, and you may need to sort of think about either a longer wean to an Impella device off VA ECMO versus bridging to a durable support or so some sort of other exit strategy. So I think just the presentations, the etiological presentations may require focused assessment when you're thinking about designing RCTs.
No, Verinder, I think you're right, and we certainly appreciate those with a acute on chronic heart failure complicated by shock. You must be thinking of an exit strategy given recovery is much less likely. We see it sometimes, but much less likely. So yeah, very multiple considerations, right, which make it difficult to task. So Randy, going back to you, just in terms of what you would like to see as next steps in terms of moving this space forward.
Well, I think Verinder hit the nail on us. I think you've got the first thing you have to do is decide if you're on a recovery track or if you're on a destination track. So, for example, if it's acute fulminant myocarditis, my bias would be to completely unload the patient and you're shooting for recovery. If it's chronic heart failure, then it's a bit different. So I think you need to really separate the patient populations based on etiology. And then my bias would be to not complicate things with a balloon pump in it, but just to try to answer the question with Impella. But then you have to really make a lot of definitions as far as how much unloading you're going to allow. So I think it's pretty complicated, Jerry, and I think we'd have to have a lot of discussion.
Venu, final comments.
I think we have Sanjeev and Jaime with their hands up. I don't know if they wanted to comment.
Oh, forgive me. I missed that. Forgive me, please.
Yeah, no, I think the biggest, this is Sean here, but my confusion when it comes to these devices is really the hemodynamic trigger and how we sort of look at unloading. And we talk about wedge pressure and saying what is an optimal wedge pressure for a patient to have, because I think every time I look at the Dan Burkhoffs looking at their pressure volume loops, I think decreasing myocardial oxygen demand for the myocardium is so important. But, just for an example, we had a patient on VA ECMO with a balloon pump in J31 where the wedge was 2025, and you would think they would need an Impella for unloading for a guy with chronic heart failure, and he did fine with just a balloon pump with a wedge of 2025 coming off of VA ECMO. So I think there is, a lot of uncertainty even looking at some, hard criteria when you look at unloading and things like that. And I don't know if anyone else has ever had those types of issues of when to escalate versus when people can like sneak by, even though their hemodynamics are not pristine.
Yeah, Sean, it could be challenging, but my bias is always to mitigate sequelae for ongoing incomplete LV unloading is to try to keep that wedge under 18, but one can challenge that cutoff, especially for acute on chronic heart failure patient. Jaime, please ask the question or comment. Thank you.
Oh, no, thank you. This was wonderful. No, I just want to echo sort of Randy's thought that it's important to just separate perhaps, and there's so little written in the heart failure related cardiogenic shock, in which, the ranges of therapy with an abnormal, left heart predominant or biventricular predominant shock of therapies, they're so heterogeneous that can start from nitroprusside to contrapulsation to 5/5 up front, and defining those transitions and trajectories to native heart survival, replacement therapies, and or palliation and futility. We need to know, which patients will be defined based on that. But it also asks the question about access to those therapies. A lot of, we are blessed to work in places in which we have access to everything. But as Penny was mentioning, when time zero starts in these referral centers, and we jump all the way up to ECMO and Impella without a transition stand situation, and these patients have heart failure shock and being following